Hello, my name is Nguyen. I'm an ER critical care doc. I'm going to be talking about mountain medicine on this lecture. Next slide, disclosure. The first thing I'll talk, which is kind of interesting, is high altitude sickness. I'm very interested in wilderness medicine, and I'm actually part of the fellowship program. And I do a lot of medical mission too. And one of the things that we generally do for our group is to do medical camps, and then after that do some sort of trek. And in the last 5 to 6 years, we've been working in Nepal and India, and we've been trekking the Himalayas. And actually 2 years ago, we didn't go last year, this year or 2019 because of COVID. But the last time we went, we actually trekked Everest Base Camp and further up. And when you do mountain trekking and stuff like that, you know, people don't appreciate altitude sickness, but it's pretty important. You know, it can kill people. So during our trek with our group, we actually brought medication along for our group, but also to, you know, treat other people foreigners who are trekking who don't appreciate altitude sickness. So on the way up to Everest Base Camp, we actually treated a lot of people who otherwise would have been flown out with helicopter. So, you know, it's very satisfying to you know, understand the pathophysiology and to treat these people who are extremely grateful helping them. Okay, so altitude sickness, risk factor wise, you know, there's a lot of risk factor, but, you know, people who are very young or very old are at risk. People who have heart and lungs problem are at risk, especially, you know, people who have like sickle cell disease are at risk. But anybody can succumb to altitude sickness. Doesn't matter, you know, your age, your gender, or how fit you are, you can succumb to altitude sickness. Generally, you shouldn't develop any symptom unless you're above 8,000 feet. Once you're at 8,000 feet, the risk of getting altitude sickness is, you know, is higher. And that's, you know, has to do with the oxygen pressure and the amount of oxygen up high. As you can see on the chart on the right, the higher you go up in terms of altitude, the higher the oxygen level, the lesser the oxygen level is. And like I say, anybody can succumb to altitude sickness. Hypoxemia at where you sleep. So breathing issue where you sleep, it's very important. And you need to acclimate before you ascend further. When you're above 10,000 feet, it is highly recommended that you ascend no higher than 500 to 1,000 feet daily. And of course, you got to slow down if you start developing some mild symptoms. Okay, so next slide. Pathophysi, when you increase the altitude, you decrease the partial pressure of oxygen. And when you decrease the partial pressure of oxygen, there's less, percentage of oxygen in the air. And that leads to hypoxia. So generally, physiologically, your body tries to compensate as the partial pressure of oxygen decrease. The carotid body in your carotid arteries by the neck responds to the low level of oxygen partial pressure by stimulating ventilation. When you stimulate ventilation, which means that you increase your respiratory rate by breathing faster, you increase pretty much your tidal volume. Tidal volume, you know, in terms of lungs mechanic, is respiratory rate and the level of oxygen. So when you increase your respiratory rate to try to get more oxygen in, you decrease the the level of carbon dioxide that you release. And so this will increase the, you know, the partial pressure of the oxygen. Your kidney try to respond to, because when you increase your respiratory rate, you you develop a respiratory alkalosis. And when you develop an respiratory alkalosis, you know, it takes time for the kidney to increase your to excrete more bicarb from your kidney in response to the overall, you know, alkalosis in your body. And it also increased the erythropoietin to produce more red blood cell. And usually it takes about, you know, 2 days, 1 to 2 days for all these, you know, metabolic adjustment. Respiratory adjustment can happen right away, like within seconds and minutes, but metabolic adjustment, you know, via the kidney and other mechanism takes some time. And when your erythropoietin increase, it shifts your oxygen hemoglobin curve to the right, so that, you know, your oxygen get released, you know, improved release of the oxygen to the tissue. Next slide. So, like I say, altitude sickness can cause, you know, you probably become symptomatic above 8,000. Sometime rarely you can see above 7,000. Usually within like 1 to 6 hours of the high altitude, you develop, you know, the most common sign is headache and fatigue. Sometimes decreased appetite. And at night, characteristic too is you develop like, you know, sleeping issue. And then while you're sleeping, you develop like, you know, irregular sleeping pattern as your body try to adjust. And on the chart on the right, you know, some other symptoms, you know, that are severe too, like nausea, vomiting, dizziness, and severe headache. But the diagnosis is really based on clinical judgment. Like if you have someone who you're not sure are exhausted or just, you know, having acute mountain sickness, I would assume that it's more mountain sickness than exhaustion from trekking, you know, whatnot. Next slide. Once you develop some signs of acute mountain sickness, AMS, you should not ascend until your symptoms improve, until you acclimate. And generally it takes about 1 to 2 days. And if you develop severe symptom like throwing up, cannot stop, severe headache, and especially if you develop, you know, problem walking, you know, severe breathing problem, you should definitely descend without trying to stay at that, you know, altitude that you're develop these symptoms. Descending is kind of like the mainstay management. If you cannot descend for some reason, then supplemental oxygen to help with the oxygen requirement. And of course, Diamox or acetazolamide. Acetazolamide will increase, you know, your body acclimation process. And some people will actually take it prior to ascend because they have a history of, you know, mountain sickness in the past, or if they're, you know, want to take it prophylactically. And the other management, so, you know, generally we do oxygen, we do Diamox, and we do dexamethasone. And then for headache, you do Tylenol, but, you know, it's better if you do Motrin, which is an NSAID. And, you know, I'll explain a little bit why. The thing that you try to avoid with your ascend is anything that will suppress your respiratory, like alcohol, narcotic, benzo, and dehydration and overexertion. Next slide. So earlier, it's just altitude sickness symptoms. When it progresses, it can develop into high altitude pulmonary edema. And you can go straight to high altitude pulmonary edema without, you know, symptoms of altitude sickness. So high altitude pulmonary edema is a non-cardiogenic pulmonary edema. It generally occur often, but not always, 2 to 3 days after arrival to the high altitude. And like I say, you don't generally develop this unless you're above 10,000 feet and you do rapid ascent. It's fatal if you don't descend and you get treated. The symptoms is often with, symptom of AMS, like, the headache, the malaise, the sleeping problem. But you'll develop like, shortness of breath, dyspnea on exertion, or, dyspnea at rest, fever, confusion, difficulty walking, and suspicion will be clinical. If you happen to have a clinic or a hospital at the altitude, or even if you descend and go to a hospital, a chest x-ray will show vascular congestion and pulmonary edema. And the cause of this is that when you go into high altitude and the partial pressure of oxygen is decreased and you don't have enough oxygen, the lung mechanic first response will be vasoconstriction in the capillary beds. And the reason being is that you want to increase flow so that there's improved gas exchange. However, when you have significant pulmonary vascular constriction, it causes high hydrostatic pressure within the capillary beds. And when you have such a high pressure over a long, not a long period of time, but over a period of time, you develop leakage. And that's what, is the interstitial edema. And interestingly, since I'm, talking about COVID as well, when we started out with the pandemic, there was like comparison, maybe, the Pathophysi of the initial stage of COVID was similar to high altitude pulmonary edema. And we did, some of these patients, we actually Swan-Ganz them, put a right heart catheter in them. And we found that, initially, early on, the physiology and the number that we got from the Swan-Ganz is actually similar to high altitude pulmonary edema. But then with clinical, with the disease process in COVID, it became more of ARDS physiology, which makes sense. But anyway, going back to high altitude pulmonary edema, yeah, you really need to descend if you develop this. You cannot stay at the altitude where you are and try to acclimate. You got to descend. That's, otherwise, this will progress and people, you can die from it. So next slide, the treatment for when you develop, here it talks about Pathophysi, which is the pulmonary constriction that I told you about. And on the right, it gives you a kind of like a schematic of that. And we already talked about, the management, which is immediate descent. And generally you recommend, I would recommend at least 2,000 to 3,000 feet descent. And if they don't, if they feel better, but they still, can't breathe that well, a complete descent. And if it's bad enough, they need hyperbaric oxygen. And we have a portable one, generally with, an Everest or, an area where there's a known path, where there's a lot of people trekking. There's a portable hyperbaric chamber called the Cabal Back, and I can show you that in a little bit. Medication-wise, other than supplemental oxygen, you can start them on nifedipine, which, people can take it as prophylaxis before they ascend if they have a history of high altitude pulmonary edema. And, it's a calcium channel blocker, so it vasodilate. You can also use Viagra, which is sildenafil, which is also like a pulmonary vascular dilator. And, people sometimes would recommend steroids, others don't. The literature about it is kind of not really that great. But, in my experience, I give them, just because of the Pathophysi of the severe vasoconstriction. And also, when they develop high altitude, symptom, especially with AMS, steroid, in my opinion, has helped too in the past. So next slide, high altitude cerebral edema. This is your most severe and the most fatal, I would say, but it's not the most common fatal. The most common fatal will be your pulmonary edema. But it usually kicks in the same thing as pulmonary edema 2 to 3 days after arrival, greater than 10,000 feet, and it's rapidly progressive. And it can lead to brain herniation and death within 24 hours. Generally, you can get AMS symptoms with this. You can have pulmonary edema symptom with this, but some people will directly go into cerebral edema. And one of the most common sign and sensitive is ataxia and confusion. So if you have someone who's checking with you, going up to high altitude, and they have problem walking and they have cerebellar signs, then you gotta be highly suspicious for high altitude cerebral edema, and they need to descend rapidly. Sometimes you can have, these people can have coma, seizure. Retinal hemorrhage is actually pretty common, and cranial nerve palsy. The way that you diagnose is clinical, but once they descend and go into the hospital, get an MRI and or a CAT scan. And on the right is a schematic. So the path of Fizz here again is also, severe vasoconstriction and capillary leakage with an increased intracranial pressure, and that's the same as the pulmonary edema, when your brain is hypoxic and vasoconstrict to try to increase flow, and that causes capillary leakage. So here you do supplemental oxygen. Here, study have shown that steroids has helped improve the mortality in cerebral edema and decrease ICP. You also do Diamox, and then you also do hyperbaric, O2 as well. In the past, some people have used, mannitol or natremic, fluid to try to see if they can improve the ICP. That's kind of really controversial. I would say immediate descent and evacuation, steroids, hyperbaric O2 or supplemental O2, and get them, evacuate quickly as you can. Next slide. So this is just an overall schematic for, the Pathophysi of lung and brain injury with high altitude sickness. Next slide. So let's go over some medications that we use. So acetazolamide, Diamox, the general dosage for it is 125 to 250 BID before you ascend, if you're going to use it for prophylactic, medication. And usually you do it 24 hours, 24 to 48 hours before you ascend. The way this works is it's a carbonic anhydrase inhibitor, and what it essentially do is in the kidney is it causes your kidney to get rid of bicarb, and that in turn will cause a metabolic acidosis. And when you develop an acidosis, you hyperventilate, and this is also contribute to the hyperventilation of the brain, increase minute ventilation, which increase your tidal volume and increase oxygen. And so you kind of like bypass trying to help the kidney, because like I say, the kidney takes about 1 to 2 days to acclimate, but when you use this, you acclimate much better. So the indication is to prevent altitude sickness or to treat it. So in any stage of the altitude sickness, whether there's lung or cerebral involvement, you use Diamox to try to get the kidney to acclimate better. And it's a SOFA-based medication, so make sure your patient is not allergic to SOFA. The most common side effect, I would say, especially with higher dose, like the 250 twice a day, is the oral and digital paresthesia. And some people say that they develop a bitter, taste with carbonated drink. Next medication is the dexamethasone, the steroid. The dose for this is 4 milligram BID for prophylaxis, and every 6 hours when you treat it. Whether you're treating the AMS, the pulmonary edema, or like the cerebral edema. And what this does is it decreases the vasoconstriction and decrease the capillary leakage. And it's also an antiemetics too. So generally, if you have a history of cerebral edema or pulmonary edema, you should, consider taking this as a prophylaxis. It does not help with the acclimation, but it helps with the symptoms. Nifedipine is a calcium channel blocker. You take it 30 milligram twice a day, and it vasodilate, particularly to the pulmonary vasculature. And we use it to treat and prevent pulmonary edema, high altitude pulmonary edema. Viagra, sildenafil, 50 milligram Q8, is a phosphodiesterase 5 inhibitor. What it does is it increases cyclic GMP, and that causes pulmonary vasculature vasodilation. And we use it for pulmonary edema. And NSAIDs, like Motrin, Naproxen, it's possible preventative prophylactic secondary to inhibition of prostaglandin. And there's literature about it in the Wilderness Medicine journal about it, that people who take it prior to and during, when they develop symptoms of headache, they get better. And if you look on the right, you can see that the arachidonic acid, and what's caused the symptom. Can you hold on? Hello? Yeah, I was.
2, 1, all yours.
Okay, so the next slide will show you the Cabal Back that I was talking about. And this is actually at Everest Base Camp. So it's just like a little bag that has, that you pump up, and it's a portable hyperbaric, and it's pretty effective. It can take your, decrease your altitude by almost 10,000 feet. So, yeah, it's very effective. Next slide. So one of the more common coughing and coughing is what we call bronchitis. Almost, everybody developed this in my experience. And I would assume that this is part of the altitude sickness as well. But, you don't really need to ascend. You can continue to ascend. You don't need to descend. But it's pretty common, and it's that vasoconstrict that I talk about, but it doesn't do any injury to the lung. When people do have this, the chance of them going to altitude pulmonary edema is the same as, people who don't have these symptoms, but it's pretty common. And, you can do albuterol to to bronchodilate. Antibiotics is not helpful. Warm steam will actually help. So next slide. The other, high altitude sickness that people don't appreciate is the retinopathy. It causes retinal hemorrhage and optic nerve edema. And generally this can occur above, I would say above 14,000 feet rather than 16. You'll see, like people who have retinal hemorrhage, like the floaters, the eye pain, the visual change. You diagnose this with fundoscopic exam, and you can actually use the ultrasound and take a look in the eye. Descend if you have these symptoms, any visual symptoms, and it generally resolve within 2 weeks. So next slide. Before we go into co-injury, I just want to let you know that for high altitude pulmonary edema and also cerebral edema, having a portable ultrasound with you, one of those pocket-sized one, is very useful. So when we trekked up to, you know, Everest Base Camp, we actually went above. Everest Base Camp is about 17,500 feet. We went above it to about 19 or 20,000 feet. We have trekked the other part of the Himalayas too. And we always carry a portable pocket-sized ultrasound with us that doesn't require internet. All, you know, it requires battery. And it's very useful, especially in the wilderness, because you can diagnose fractures, you can diagnose, so for fracture, you just put a probe on and see if there's a break in the, you know, hyperdensity of the, you know, echocity of the bone line to see if there's a break. And then, you know, it's also useful for pulmonary edema because if you put a probe on them and you see, you know, B lines, normal is A line. If you see B line with shadowing, then they have fluid in their lung. And so you can diagnose pulmonary edema right then and there. And for cerebral edema, you know, with the skull, you can't really, you know, ultrasound that, but you can ultrasound intracranial pressure by ultrasound the eyeball. And there's literature about this that's pretty, you know, sensitive, the sensitivity of it to increase intracranial pressure. And what you do is you ultrasound their eye and you look at the optic nerve and the depth of the optic nerve and you measure it. And the size of it, the diameter of the optic nerve, you can actually, you know, kind of correlate to ICP level. And so, like I said, we always bring an ultrasound with us, you know, to help kind of diagnose what's going on, you know, and then from there, you know, determine whether the patient needs to be evacuated or immediate descent. So yeah. So in terms of co-injury, frostbite will be your most, you know, tissue damaging, and it's due to freezing of the tissue. And it correlates not with just the temperature, but also the wind speed, which increase the temperature of the tissue. The most common site of injury would be your, you know, distal extremity, like your digit, and also your face, nose, and ears, places where you're exposed. And of course, the Pathophysi would be the co-injury, where you get severe vasoconstriction and crystal formation or ice in the tissue, and that causes damage, cell death. And when you have cell death, you have, you know, cytokine release, and you have platelet aggregation, and that causes thrombosis. And that further causes tissue injury. And furthermore, you have to be careful with, you know, rewarming, because if you rapidly rewarm them, you can cause secondary reperfusion injury with, you know, cytokine release, like I say, and oxidative radicals that further, you know, injure the tissue and cause further cell death. The zones of injury is important, just like a burn, you know. I mean, frostbite is pretty much, you treat it like a burn. So the area of hypothermia is the area that, you know, least injurious. The area of stasis is the area where it's severe, and the, but however, the, you know, the damage can be reversible. The coagulation area is the most injurious, and the damage is generally irreversible. And the picture on the right kind of give you a little schematic of early, late, and you know, the thawing phase of co-injury. Next slide. So generally, you don't appreciate the full extent of the injury until you're 6 to 8 weeks out. And like I say, you categorize it like, you know, a degree burn. So there's 1, 2, 3, and 4. And on the right, it will, you know, there's a schematic of the tissue, you know, involvement. So first is partial thickness. You know, generally they have throbbing, some tingling, some redness. Second degree, full thickness, they would develop, you know, blister within 24 hours. They're painful with the rewarming. Third degree, you involve the subacute tissue. You get a lot of pain and you develop hemorrhagic, you know, blisters and necrosis, and you develop severe pain with rewarming. And fourth degree, it's all the way down to the muscle, tendon, and even bone. Generally, the nerve are injured, severely injured, so there's minimal pain, and there's, when you rewarm them, there's generally no pain because of the nerve injury. Next slide. I mean, in terms of diagnosis, it's a clinical diagnosis, but you get labs just to make sure their electrolytes are okay, their CBK is okay, that they didn't develop rhabdo. But the management is, rewarming, and you have to rewarm with care, right? And provide pain management, wound care with tetanus, elevate the extremities, dress it, topical antibiotic. And in some cases, if it's severe enough and you think you can salvage the extremity, before you wait and, consider, amputation after 6 to 8 weeks, you can do TPA. Just try to see if you can help with the thrombosis within the vessel. And then, of course, like I say, surgical amputation and debridement if need to. Neural sequela for this is, chronic pain, and then also sensory issue, especially when you're in the cold. Prevention, of course, for this is avoid, rapid change in temperature, and especially temperature that's less than 5 degrees Fahrenheit. Make sure you wear layer clothes and cover all your extremity, including your nose, your ears. Hydrate, stay active. Avoid getting wet, of course. Stay dry, and avoid any medication that will make you alter your mental status. Next slide. So hypothermia is also pretty common. Actually, you will develop hypothermia usually before you develop the frostbite. So by definition, hypothermia is when your core temperature is less than 95 degrees Fahrenheit or 35 degrees Celsius. Usually with this, you develop, shiver with it as a reaction by your body. With muscle contraction, try to produce heat to warm you up. Mild hypothermia is around 32 to 35. Moderate is, 28 to 32. And severe is anything less than 28 degrees Celsius. When you're less than 32 degrees Celsius or 90 degrees Fahrenheit, you are at risk of getting a supraventricular dysrhythmia. And then when you're lower than 30, you're at risk for getting ventricular dysrhythmia, like VTAG, VFib. According to ACOS, life support, defibrillation and ACOS medication like epi, amio, and all that, it's ineffective until you're warm, like at least 30 degrees or higher. And so in cases like that where you have VFib or asystole in a cold patient, you gotta rewarm them while you do CPR. And you can't call the you can't call the patient that they're dead until they're at least 30, and for me at least 32 degrees Celsius. And we have cases where you read in the literature, which I have not personally experienced, where patients are actually put on ECMO to try to rapidly rewarm them, instead of continuously doing CPR while you try to rewarm them rapidly. Signs and symptoms are at least, like what we mentioned, shivering, confusion, headache. There's cold diuresis, meaning that, as you vasodilate while you try to rewarm, you cause vasodilation, and that causes, dumping of the kidney of bicarbs and, fluid. So the way that you diagnose this is, of course, the most accurate would be your bladder and esophageal temporal. If the patient is not intubated, bladder, but if they're intubated and you can put a esophageal probe in there, that would be better. You get EKG, you get lab works, and of course, EKG, not always, pathognomonic. You would get the OS1J wave, which is the little bump with the, after the QRS interval. The most common that you'll see is sinus bradycardia, and, uh, PR interval prolongation, and then also QRS and QT. You also will have like, AV blocks as well. And if severe enough, you get supraventricular and ventricular dysrhythmia. Next slide. So the way you treat this is rewarming. So how much you should rewarm and what methods? So generally, if it's not severe and if their core temperature is above 32 Celsius or 90 Fahrenheit, you have some time. You should do passive external warming, meaning that you remove anything that's cold, you remove their clothing, you put them in a heated room, you put them on a bear huggers and try to warm them up. Generally, they don't have a problem with this. You should actively rewarm them and also passively rewarm them if their temperature is less than 32, or at least like 30. You should actively rewarm them. And active rewarming, meaning that you warm water, like really heated, blanket, radiant heat with some sort of heat force, bear huggers, humidify air, and IV fluid, as well. And if it's severe enough, if it's less than 28 or like less than 20 degrees Celsius, and they're like heart rate is like in the 30s, 40s, complete ultramental status, you should actively internally warm them. And this involves getting them, IV fluid, warm IV fluid. You can do warm lavages, and that, you can do bladder lavages with warm water. Severe enough, you can do peritoneal and also esophageal, warm lavages if they're intubated. Most of the time, if they're like less than 28 degrees Celsius or less than 20, they're going to be intubated because they're not going to, their respiratory rate will, decrease as well with severe hypothermia. And so you're going to need an airway. So you're going to intubate these patients. And like I say, if you need to, really rewarm them because they're in asystole or VFib, then ECMO would be your best. There's also in the past attempt for dialysis and then, rewarm them that way as well. But just be mindful that when you start rewarming patient rapidly, especially when you do it above 1 degree Celsius per hour, there can be a lot of issue. People can drop their blood pressure because you're vasodilate them peripherally, and that can drop their blood pressure. You can cause a lot of, you can cause cell lysis if you warm them up too quickly and too rapidly. So you have to follow their lab work, essentially, make sure their potassium are okay, because if you're not mindful of that and you rapidly, rewarm them, they can, it can cause like high potassium from cell lysis. So, usually, depend on how quickly you rewarm them, get lab works like every 2 to 4 hours until they get above 32 or 33 degrees Celsius. That's generally the safe, kind of area when you're not too concerned about. That's pretty much it. I'll take some questions, and these slides are a little bit short. I just mainly focus on the mountain medicine altitude sickness, which to me is very interesting. So, let me know if anybody has any questions. Thank you.